Good afternoon, doctors. Welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare. Hetero Healthcare is an innovative pharmaceutical company. Our journey began in 1993, and we have got 30 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in our portfolio and presence in 126 plus countries. With 21,000 employees globally, we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, introduced Oseltamivir, Favipiravir, and Remdesivir, for which they received an award of Pharma Excellence in August 2020 for COVID drugs. At today's webinar, I'm a role of Oseltamivir in flu management. We have got moderator Dr. Pramod Jog, sir. Welcome, sir. Dr. Sanjay Nathu and Dr. Sainath Pawar. Welcome, Dr. Nathu. Welcome, Dr. Pawar.
Yes,
Dr.
thank you.
Pramod Jog, is Professor of Pediatrics, D.Y. Patil Medical College, Pune, President IIP 2016, Steering Committee Member GAVI CSO 2016 to 19, Chairman Mini Recipe Module IIP, author of book Cophology. Dr. Sanjay Nathu is MD DNB Pediatrics, MNAMS, FACEE, presently Professor and Head of the Department Pediatrics from March 22 till date in Srimati Kashibai Navle Medical College and General Hospital, Pune. Sir is Consultant Pediatrician, Shashwat Hospital, Kothurud, Pune. Areas of interest include pediatric pulmonology, pediatric infectious disease, pediatric emergency medicine. Dr. Nathu is President IIP Pune Branch 2021, member of Pediatric COVID Task Force Pune Division, organizing team member of numerous national and state pediatric conferences training, member National Academy of Medical Sciences India, fellow of Academic College of Emergency Experts, membership is Indian Academy of Pediatrics, Indian Medical Association. Dr. Sainath Pawar is MBBS MD Pediatric, DCH FCPS. Sir is fellow in allergy and asthma from University Hospitals, Leicester, UK. Certified pediatric flexible bronchoscopist by APPS and IIP, consulting pediatrician and pediatric pulmonologist, consulting allergy and asthma specialist, President Kolhapur Academy of Pediatrics 2024, National Trainer for NTEP IIP Action Plan, National Trainer for Pulmostar IIP Module, National Trainer for IIP REAP Module, Executive Board Member for Maharashtra Respiratory Chapter of IIP. With this brief introduction, I hand over the session to Dr. Pramod Jog, sir. Over to you, Jog, sir. I stop sharing my screen.
Sure. I will just share my screen so that we can start. Yeah, thank you. Just okay. Are you able to see my screen? And
Yes,
can you?
sir. Yes, sir. Yes, sir.
Thank you. So we'll start with today's discussion. Very good. So good afternoon, all my friends. And today we will be discussing about the use of oseltamivir in flu management. It's a topic of great importance today because the monsoon is in full swing, and you can see that the people who are happy during the monsoon, they are the farmers because the monsoon is in full swing. The frogs have come out of the hibernation. The doctors are happy because there is lot of footfall in the OPD, and farmers are also happy because of the sale of the medicines. The most important thing is that there are so many viral infections going on, like flu, RSV, that the pediatricians are very, very busy in the practice, and it is essential that they know about the various illnesses during monsoon, particularly the viral illnesses. As far as I am concerned, I was the strain of IIP presidents of 2016, and I have put my name in the manner of the influenza virus, which usually includes the place of origin, the month and the year of origin, and the name of the virus. So, as I told you, when people used to say that, the illness is viral, quite a few years back, usually I, was not much worried. I would say, okay, it's viral, nothing to worry about. But then, over years, after the 2009 pandemic of influenza and the COVID-19 pandemic, now I am a bit worried. So whenever someone says it's viral, so many things come in front of my mind, whether it is going to take an unusual turn, whether it is likely to present like something else and later on turn out to be a virus like adenovirus, okay, or whether it is going to have, some cytokine storm. So we have witnessed the rise of these viral infections over last few years. And basically, Dr. Sanjay, I would, ask you as to what is your opinion about, the viral infections over last few years. Do you think that there has been a rise in these viral infections in general?
Good evening, sir, and good evening, everyone. Yes, a very important question because I am sure all of us pediatricians will agree that the number of patients presenting to us with a viral infection are more than what they were about, say, 5, 7 years back. There are multiple probable reasons for it, and one of the most important reasons could be the prevalence of vaccination against many of the common bacteria which used to cause infections in children. As a result, these infections have gone down, and the number of viral infections are very high, especially in this season of July, August, September. Predominantly, we get viral infections as compared to bacterial.
Right. And moreover, I'm sure you'll agree with me that during the COVID times, we never had the immunity against some of these viruses. And there was a term which was used, which was called as immune debt. The people in general, they were inside the houses, children were also inside the house. And that's why they did not develop much of immunity against the viruses. And if you see, after COVID, maybe the latter half of 2022, there were different viruses like RSV, the hand, foot, mouth disease, then the adenovirus. All of them, they started showing up from different parts of the country. And I remember measles also in some parts of the country where immunization was not up to the mark, was showing a bit of an upsurge. So it is important that we are aware that the OPDs now are getting, full with children with recurrent respiratory infections, these viruses complicating into otitis media, some of them with adenoidal hypertrophy, and as I said, the adenovirus, which has started behaving like a badenovirus, and so on and so forth. Now, the most important thing is that in addition to those waves of different viruses, even the older children are getting affected. And one should be aware that when an older child comes, we should always remember that viral infections can affect older children also. So, a few days back, I witnessed a case where it was a 3-year-old boy who came with fever, cough, cold, and progressive breathlessness over 3 days. Came with tachypnea with hypoxia, and the X-ray was showing ARDS, and was admitted to the PICU, was ventilated, received oseltamivir along with supportive therapy, and on investigation, he turned out to be positive for H3N2. He was ventilated for 3 days and then he was all right. Now, in a previously healthy child presenting with cough, cold, fever, progressing over 3 days, whether the treating clinician could have prevented this progression, and whether every patient of cough, cold, fever be given oseltamivir upfront in the flu season, that is, something which, started bothering some of us. And this is the reason why, there were certain things which I say as confusing points, okay, because these are the confusing points related to flu. So whenever a child comes with viral or bacterial respiratory infection, the first thing is to find out whether it is bacterial or viral. If it is viral, what is the likely virus, whether it is a rhinovirus or adenovirus or influenza? If it is influenza, whether this is H1N1 or H3N2, and whether I should start oseltamivir upfront, and whether I should give every patient antiviral to play safe. So, in today's discussion, we are going to discuss some of these important issues. And as all of us are aware, there are so many healthcare related challenges in monsoon, including influenza, and the incidence of influenza and the related deaths are increasing alarmingly in India. We should be aware that influenza basically is of three types. Influenza A, which causes frequent epidemics due to minor antigenic variations. See, there are some glycoproteins, H and N, which I will be telling you now, and they are basically having their own amino acids. So when the amino acid sequence changes, which occurs roughly every year, there are some, minor antigenic variations which lead to what is called as drift. And influenza A is the one which is responsible for periodic pandemics because it is mainly seen in human beings as well as animals. So whenever the different viruses they combine together, for example, the virus from the birds and the virus from the human beings, when they come together in an animal like a pig, the pig acts as a mixing vessel, and then there is a new virus which emerges, and that leads to periodic pandemics. Influenza B infects only humans, and that is why it doesn't produce pandemics. It produces only local epidemics. And as I was telling you, hemagglutinin, HA, and NA, these are the two glycoproteins. And when the influenza virus enters into the respiratory system, it attaches to the respiratory epithelial cell with the help of hemagglutinin, and then the RNA of the virus enters into the respiratory epithelial cell. So for the entry, HA is the key. So that's why it is called a molecular key, which allows the virus to enter into the respiratory epithelial cell. Inside these RNAs, they multiply, so many virions are produced, and they are waiting to get out of the epithelial cell, where this neuraminidase comes to the help of the virus. And this neuraminidase protein of the virus is like a molecular scissors. So it will, like a scissor, cut all those different virions and allow them to get out of the respiratory epithelial cell. And these virions, then they attack other respiratory epithelial cells. And this is how the virus spreads from one cell to other. And that's why when we use oseltamivir, which is the neuraminidase inhibitor, this particular release of the virions is inhibited. Uh, I always say that these viruses like influenza and COVID, these are RNA viruses, and they are naughty viruses because they change their structure very rapidly. And that's why we have to change even the vaccine every year. So it's very important that we know many things about these viruses. And there have been four major global pandemics: 1919, the Spanish flu; 1957, 68, and 2009. So, there have been the major global pandemics. And now, Dr. Pawar, we have this influenza in the atmosphere, and every one of us is witnessing so many cases. So, do you have any recent updates about the epidemiology and the circulating strains of this particular influenza virus in the maybe you can give your opinion on this. And Dr. Nathu, you can also give your opinion if you have any information. Yeah. Yeah, Dr. Pawar, you'll have to unmute. You are on mute.
Nowadays, actually, H3N2 is more common nowadays,
Okay.
as we are seeing. But actually, I am practicing in Kolhapur, so we do not do too many of influenza virus means this reports because most of our patients are not very affording. But the patient, if they are affording, then we will do the influenza test, and many of them are this year at least H3N2 strain is more common seen in this area in this year actually we can say. And and always there are means last year also I think it was H3N2 was prominent. So that is the thing. H1N1 was there few years back, but nowadays H3N2 is more common, and we are treating those patients with Oseltamivir. If the patient is affording, we'll go for the test. Otherwise, we'll treat directly with Oseltamivir.
Right, right. And
So
Dr. Nathu, do you have anything to add?
Yeah, in Pune, we are lucky because we have the National Institute of Virology, which does the studies of the nasopharyngeal swabs. And so this year, we have been sending samples regularly. And what we have found, as Dr. Pawar rightly said, H3N2 is the predominant strain which has been isolated for the last couple of months. Occasional H1N1 and even an occasional influenza type B is also being identified, but the majority of them are H3N2. Of course, the proportion of H3N2 fortunately has been now decreasing in the last 15 days or so, and we are also getting RSV in the recent past. But yes, H3N2 is the most predominant strain which you have been seeing this year.
That's very good. I will just tell you that in India, the eastern part of India is the one where we get this type B, very commonly. And it's also noticed that whenever some major pandemic gets over, for example, now COVID pandemic got over, and then these influenza viruses, they start coming up. And type B was the virus which came up after this pandemic of COVID-19 came down. So that's something which great to know. And we all know that the flu virus is transmitted from the people to others up to about 6 feet. And these viruses are spread mainly by the large droplets. And when people cough or sneeze, they go and sit on the mouth or the nose of the person who is in front, or also on the nearby surfaces like the table or the handkerchief or the hands. And that's why the spread occurs not only by directly by droplets but also by these fomites. And that's why it's necessary that we take all the precautionary measures. Okay. Dr. Nathu, what are the different clinical scenarios with which you have seen influenza virus attacking children?
So very commonly we are getting patients, children who are presenting with fever, cough, sore throat or throat pain, some runny nose, some headache and some body ache and generalized weakness sort of picture, which has been very common in this last couple of months. And we are also getting family members being affected one after the another. So there may be other family members who are also affected in the same time frame. These are the most common pictures. Occasionally, the body ache tends to predominate. Mostly, these turn out to be influenza B. But otherwise, the typical fever, cough, cold, body ache, headache picture is there. And the occasional complications are also being seen. Many children are presenting, not many, but of course, children are presenting with febrile seizures. And the child on investigation for febrile seizures, the cause is found to be viral infection because of the influenza virus. Gastrointestinal symptoms are there, though not very common. We do get them occasionally. And the encephalopathy and myocarditis, though rare, have also been seen occasionally in this year because of the number of patients of influenza have been so high. So indirectly, the number of complications which we have seen is also a little bit more than what we have seen every year.
Sure, sure. And Dr. Sainath, do you have any additional patients that you have seen?
No, sir. No, sir. Same.
Yeah.
Only thing, generally, if the I will in my cases also I am showing it that if the patient is becoming drowsy, then you think more of this influenza viruses. Either their WBC count will be going down and there will be more of influenza viruses.
Yeah. Okay. In general, maybe our listeners can just remember that there is a broad group of what is called as influenza-like illnesses, which have fever, cold, and cough with which they present. And I always say that influenza is the father of all those influenza-like illnesses because it is basically a systemic illness where the child gets headache, the child will have pain in the muscles, weakness, and to such an extent that an older child who is 8 or 10 year old also is lifted by the father and brought to the OPD. So the weakness is quite a lot. And it's also important to know that being a viral illness, other systems are also involved because we know that viral illnesses are multi-system illnesses, and that's why the other systems like GI tract, which produces vomiting and diarrhea in few cases, are also affected. So we will see some other complicated cases from our esteemed panelists in due course of time today. And we all know that influenza like illnesses, H1N1, severe acute respiratory illness, and COVID-19, all of them have these features more or less in common, though in some of them some symptoms or signs will predominate, in some others, some others will predominate. The most important thing that one must remember is the emergency warning signs of the flu sickness. And one must remember that in children, whenever a child comes with fast breathing or troubled breathing, then it indicates that the lower respiratory tract is being involved. When the child develops cyanosis, when the child is not drinking enough fluids, the child is not waking up or not interacting, or the child is being so irritable that it doesn't want to be held, then the parents should be aware that these are some of these signs where they should immediately go to the health facility. This is very important. And that is why it is necessary that we call the parents on day 3, 4, or 5, because influenza is known to be a biphasic illness. Initially, many times it so happens that the child appears to improve, but again on day 4 or 5 or 6, the child starts worsening. And this is the time when the child may require a bit of a medical help. And that's why the doctors also should be aware of the respiratory rate, whether there are some other systems getting involved, and these emergency warning signs also need to be explained to the parents. And influenza is also known to complicate into different things. And these are the things which start with the alphabet A. So they complicate as acute respiratory infections like pneumonia or ARDS, acute otitis media, absenteeism from the school in children, and absenteeism from the office, leading to loss of amdani, that is income in the parents, and antibiotic abuse. So these are the problems associated with flu. And that's why flu, apparently, many people feel that it's innocuous and nothing to worry about, but it's not so. It creates a lot of these problems, and one should be thoroughly aware of all the information related to this illness. Now we are going to come to the treatment of influenza, and then I would request Dr. Nathu to tell a bit about the different categories of influenza, and then we will come to the management based on the categorization of influenza. So before that, I will just tell you something about this antiviral drug oseltamivir, so that the further discussion will be facilitated. So as we discussed about the neuraminidase enzyme of the virus, this neuraminidase is blocked by oseltamivir, and this is very, very important, because this enzyme is critical in releasing the virions from the infected host cell. And these neuraminidase inhibitors, of which oseltamivir is the prototype, is the one which is active against influenza A and B. There is also another group of drugs which is called as adamantanes, and they interfere with hydrogen ion channel activity of the influenza A virus and blocking its entry into the host cell, and it's active only against influenza A viruses. Oseltamivir basically is a potent and a selective inhibitor of neuraminidase enzyme of the influenza viruses A and B, and it's a prodrug which is converted to the active form oseltamivir carboxylate in the liver, and it inhibits influenza virus replication and pathogenicity. It prevents further spread of infection, and it's effective against all strains of influenza A and B. And this is the diagrammatic representation which will tell our listeners that the release of new virions is blocked by the neuraminidase inhibitors like oseltamivir. It was the first oral neuraminidase inhibitor, and it is approved in more than 100 countries, and CDC, American Academy of Pediatrics, have approved this particular molecule. So, Dr. Nathu, what are the different categories for treatment, and what are the current recommendations for the use of oseltamivir in the OPD and the IPD?
Right. So this influenza-like illnesses or influenza has been divided into three categories: category A, B, and C. Category A is the usual, common, or most commonly the patients come in category A when they have mild fever, cough, cold, throat pain, some body ache, diarrhea, or vomiting may be there. These are the mild version of influenza. They do not need any effort to make any diagnosis, and they just require symptomatic treatment. In such situations, specific antiviral like an oseltamivir may not be required, and it is not recommended either. Category B is the high risk patients or severe symptoms. So category B1 is those with severe symptoms with very severe throat pain or very high fever more than say 102 degrees Fahrenheit. And the category B2 is those with some high risk factors which are present in them. For example, in adults, it may be a senior citizen more than 65 years age or a pregnant lady. In children, it may be a immunosuppressed child or a child with some underlying chronic condition, for example, a chronic kidney disease or a chronic or a congestive cardiac failure or a heart disease, and so on. So these categories of patients who have B1 or B2 type of categorization, in such situation, then we do need to start oseltamivir in these patients. However, diagnosis may not be imperative. It may not be required to be done in all cases. And based on the symptomatology and the predisposing factors itself, you can start oseltamivir. In category C, that is a severe disease. Now, these are the patients who have severe signs. For example, they may have a respiratory compromise, they may have chest pain, breathlessness, the CNS may be affected in the form of drowsiness, they may be in shock, they may have hemoptysis, and so on. So, all these patients with severe symptoms, ideally, you should be testing, but definitely you should be treating with oseltamivir as early as possible.
You can also continue and tell our listeners about the treatment
Right.
guidelines.
So category A, as I mentioned, home isolation, bed rest, lot of rest, plenty of fluids, and only paracetamol. So basically, symptomatic and supportive management is all that is required in category A. In category B, antivirals, that is oseltamivir, needs to be started as soon as possible. And testing, it is not imperative. You may or may not do the testing. It is definitely not the must situation. Whereas category C, you should definitely do the testing immediately. Admit such patients because these patients are usually admitted in the critical care setting and they require intense monitoring and supportive treatment as well as treatment for their complications. And definitely, oseltamivir is to be started as early as possible in these patients along with the testing.
Thank you. So this is the dosage and the recommendation chart for oseltamivir, where you can see that the adults usually, as a part of therapy, receive 75 milligram capsule twice daily, and children receive this medicine in the form of milligrams per kg or milligrams per day, depending on the weight band. So children who are less than 15 kg require 60 milligrams per day. Children between 15 to 23 kg 90 milligrams a day. Between 23 and 40 kg, they require 120 milligrams, and above 40 kg, they require 150 milligrams. These doses are divided in twice daily regimen. There is something called as chemoprophylaxis. What happens is many times when a child is unwell, there are some people in the family who are at a high risk of getting influenza and getting complications of influenza, like father who is a diabetic or a grandfather who has some kidney disease or someone in the family who is on steroid therapy. So they require to be protected. And for that, the dosages are given once in a day, but the treatment is given for 10 days according to the dose that has been shown in the table. Those children who are under the age of 1 year, they receive oseltamivir as a part of therapy in the dose of 3 milligrams per kg twice daily. And in young children like these, chemoprophylaxis doesn't apply. Oseltamivir is also available in the form of an oral suspension, which contains 12 milligrams per ml. And accordingly, we can calculate the dose and give it to the children. This particular chart is very important so that it will guide our listeners to treat children accordingly. Now, Dr. Sainath, how early would you initiate oseltamivir therapy? And after initiation of oseltamivir therapy early, how does it influence the clinical outcomes? So, what is your opinion about the clinical outcomes after starting oseltamivir early?
Sure. So basically, it is always better that we should start oseltamivir early, that is within first 48 hours. So if you are strongly suspecting and you are strongly suspecting of this influenza virus, then it is always better to start the treatment immediately. If illness means whenever illness is starting within first 1 or 2 days, it is best. The results will be best. So it decreases the risk of complications such as pneumonia, encephalitis, secondary bacterial infection, it also lowers the hospitalization rate. So if you're starting the this oseltamivir early, there are chances that this child will get better on OPD basis only, and it will reduce the hospital. So, and also it is stated that the early treatment is associated with better recovery with fewer long-term sequelae. So this is the advantage of starting early oseltamivir. But sometimes what happen ki sometimes we see the patient late only. So patient has treated by somebody else, and we are seeing patient at third, fourth, fifth, sixth day. So that time also there is no harm in starting a oseltamivir, because whatever benefit it will give, that will definitely help the patient only. So it is not like that ki if you are not able to start within first 48 hours, then you should not start it. Ideally, first 48 hours, but if the patient is coming to you later, better to start it so that whatever benefit he is going to get it. Let him get. So
Yeah,
also that will also help him to prevent the complications.
right. That is
Huh?
very good. This is all because it's a neuraminidase inhibitor, and whatever new virions are being produced by the influenza viruses which have entered into the system, they will be blocked from infecting the other respiratory epithelial cells. And that's why even if the patient comes late, this particular progression of the illness is halted. The chances that the child needs to be hospitalized, they are reduced. The chances that the child will die, they are reduced. And I'm aware of some institutes in Pune which had conducted research during the pandemic of influenza in 2009. And at that time, it was proved, and there were papers which were published in the authentic journals related to the benefits of oseltamivir, even after started maybe on 6th or 7th or 8th or the ninth day, particularly in children who were in the PICU. Okay, so these benefits of empiric and early use of oseltamivir have been all documented by clinical trials, and it is known that the use of oseltamivir reduces antibiotic use, influenza related low respiratory tract complications, and hospitalizations, not only in children but also in adults. And Dr. Natu, the question is whether we should start oseltamivir empirically or only after doing a throat swab. So you have already partly answered it when you told the categories, but then you can just tell what is your opinion about this.
Right. So, as already discussed, the categories are one important thing which decide whether we need to start oseltamivir empirically or not. At the same time, we should be aware about the epidemiological scenario in our particular setting. For example, in the last couple of months in Pune, at least, we are having a lot of influenza cases. So, in such situation, we are more likely or more willing to start oseltamivir upfront early. However, as has been mentioned, in category A and category B type of patients, test A patients, of course, oseltamivir not need to be given. No testing is required. And category B, the testing is not mandatory. So you may test if feasible, but that is not going to stop us from starting oseltamivir in a patient who is belonging to category A, category B, sorry, with typical influenza-like illness. And hence, laboratory confirmation of influenza virus is not necessary for most of the cases for initiation of treatment. At the same time, we have to understand that negative laboratory test, even if we get the report, but in a particular epidemiological setting, we have to give the patient the benefit of doubt and start the treatment early, irrespective of the report, if the patient is having typical influenza-like illness. Especially if higher risk individuals have been exposed to a patient with influenza, we should be more upfront in starting oseltamivir as soon as possible.
And whatever you said has been also the policy of WHO. And WHO has recommended that empiric treatment is strongly recommended. Treatment should be started as soon as possible. Laboratory confirmation of the virus is not necessary for the initiation of therapy. And negative laboratory test for H1N1 does not exclude the diagnosis. And that's why early therapy is essential. And early empiric supportive therapy and monitoring is very, very important. And even as I said, in adults with community acquired pneumonia who test positive for influenza, this particular treatment regimen includes the antiviral therapy with oseltamivir. With this, I will just take a little halt for a while and request Dr. Sainath to share some of his cases in his practice. So I will stop sharing. And Sainath, is that fine with you?
Yes, sir. Yes, sir. Yes, sir.
Okay, yeah. So you can share your cases, and then we will go to some questions and answers.
So here, one second. So my screen is visible, sir.
Yeah, we can see the information about this program, but then your slides are
Yeah.
not
Only
visible.
Gmail
I
is
think,
seen, sir.
yeah,
Acha,
you
okay.
can
Okay. One second.
maybe you
One second.
can just take the presentation on the screen. Maybe if you want, you
Yeah,
can
one
exit
second.
and rejoin, and or maybe you can just put
Now,
it.
now.
Yeah,
Yes,
yeah,
It's
yes,
seen.
yes, yes. Yeah, that's great. Yeah, you can make it full
Full
screen.
slide, sir.
Yeah, thank you.
So this is, I am just presenting two very common cases. One is our IPD case and second is our OPD case, which is
Okay.
very commonly seen in all of by all of pediatricians. So this is 3 years old female child. She was admitted with cough since last 5 days. It was dry type of cough and cold since last 6 days. Fever since last 5 days, high grade intermittent fever. Coming down with paracetamol. On examination, her heart rate is 125. Respiratory rate is 35. There was tachypnea. There was subcostal retraction. When I examined the respiratory system, there was bilateral occasional creps and bronchi. So our provisional diagnosis in this season, it was a LRTI type, but with some respiratory distress. So there was a tachycardia, there was a tachypnea, there was a retraction. So investigation was also done. Like CBC, HB was 11, WBC count was 3,500, which is showing leukopenia, in which lymphocytes predominance is seen, like polymorphs of 26%, lymphocyte of 72%, eosinophil 2%, and monocyte 2%. Platelet were 166, 1,66,000, so which was on border. CRP was normal, we can say. 4 was normal. Uh, so as this patient was having tachypnea, tachycardia, and everything, so we have admitted this patient with these investigations. And you can see here, you can see some haziness on the right mid zone, right lower zone. Typical picture infiltrations are seen. So as a routine, we started him on IV antibiotics. He was started on bronchodilator nebulizations. He was started on O2. There, saturation was borderline. He was not maintaining saturation. He was uh, he was started on O2, but still he was not maintaining saturation. So he required he was taken on high flow, and then he was maintaining on high flow supports. Slowly, tachypnea reduced, but on day three, patient became drowsy. Patient was looking sick looking child. Child was not accepting feeds. So we had done a H1N1 swab because, as I said, ki drowsy child weakness is predominant. We should always think of H1N1. So we had done the influenza actually N1 swab was done, which was positive actually, and then we have started him on Oseltamivir, and slowly over time, next 2 to 3 days, patient improved. We could reduce his high flow. We could take patient on oxygen, and slowly the oxygen was also weaned off. So this was our one case, which was IPD, which was requiring some higher support like high flow. Uh, this was our first case. So because in this case, WBC count was lower, was on lower side. Second thing, patient was drowsy, sick looking, weakness was there, not accepting feeds. All these things has prompted us to treat for influenza virus. So that was our first case. Second case is our OPD case. He is a 1 year old Raghav. Complaints of cold since 4 days, cough dry type since last 2 days, fever since 2 days. So as this was a routine OPD patient with 2 days fever. There was no specific complaints. Child was okay, feeding well, playful. So we had just given him symptomatic treatment, just paracetamol and this cough syrup. That's all. But patient came after 2 days, fever reduced, cough cold plus plus. It was there, still present. there was again the child's activity was reduced. So parents was saying that fever is reduced. So ideally, when fever is reduced, the patient should be playful. But this child is not playful, and his activity is not there. Significantly reduced activity. Child is just sleeping. So we had done a CBC immediately. The HB was 9.2. Total count was 4,500. Platelets were 2,80,000. Lymphocytic predominance was there. Dengue was done as there was the leukopenia, and patient has came with this dengue report only. So dengue was negative. This patient was not very much affording. So on OPD basis, we started him on Oseltamivir. We are not sent any reports. Influenza virus report we are not done. And then after next 24 to 48 hours, patient's activity started to improve, and patient was better, and he did not require admission also. So we had started him on Oseltamivir, and he improved, and admission was prevented actually. So this was our this was my two cases which are routine cases which we see as a routine OPD.
Yeah, so that's very good. I am glad that you brought out in the first case that the WBC count and the platelet count were on the lower side, which is also seen in children with dengue because during monsoon we do get mixed infections. And these days, quite a few children, in addition to influenza, have either RSV and we saw one or two cases only, which had also dengue in addition to influenza. Dr. Nathu, what is your experience about these co-infections and how does it affect the clinical presentation and the laboratory parameters and how we should be careful in the management of such children?
So as has rightly been pointed out, especially this year, we are getting a lot of children with leukopenia. So dengue always remains a possibility, and we need to rule it out, especially if we are not doing the the nasopharyngeal swab. Then it's definitely important that we rule out dengue because the management would be a little different with more focus on fluids and all. But occasionally we are getting co-infections. Though dengue and flu I have not seen in this year, but RSV and influenza we are getting occasionally, both of them positive. And some patients who are doing the multiplex array tests are also coming up with bacterial infections like Streptococcus pneumoniae, which sometimes occasionally the influenza H1N1 or H3N2 positive as well.
Right, right. Dr. Sainath, what is your opinion about secondary bacterial infections in influenza?
That we may get secondary bacterial infections, so we should be always aware of this, and if required, we can add on the antibiotic at the right time.
Yeah, yeah,
So
that's
if the
correct. Because
patient is again becoming toxic and the fever is high grade, in spite of starting oseltamivir, patient is not improving on oseltamivir, then we should always think of the secondary infection. That is the thing.
right, very good. Because it is known that about 25% patients of influenza, they have either Streptococcus pneumoniae or Staphylococcus aureus as
Yes.
the super infecting bacteria. It is very important. And particularly when you examine a child with influenza, it is better that you look at the throat properly and rule out that there is no follicular tonsillitis. If the child is older, you can ask him about this tenderness in the cervical nodes and also auscultate properly for air entry and crepitations at a localized place so that you can diagnose lobar pneumonia if it is present. And you should also follow up these children because it's possible that you start the treatment with oseltamivir thinking that it's all influenza, but then the child simply doesn't improve. The toxicity continues, the counts continue to remain high, and then it is prudent and wise to add antibiotics like ceftriaxone in case if there is any clinical or laboratory suspicion of bacterial pneumonias. So our colleagues should remain rather be aware of both the facts that if a child comes with a presentation of flu and the lab parameters indicate that it is flu, like the counts are overall normal, the CRP is normal, and the child is improving with oseltamivir, continue only that, then they need not add antibiotics. But if they have started the therapy with oseltamivir and the child is not improving, in fact the child is becoming more toxic and counts are not at all in favor of plain simple influenza, it is better that you continue both. So these decisions are highly individual, though rational therapy will dictate that you continue only one of them, and it all depends on the clinical presentation and the laboratory parameters and the progression of this particular child. Now,
So,
Dr. Natu, you
just
have,
a
yeah,
point I would
yeah,
like to make, sir. I think you have very well highlighted the importance of follow-up, because that is what is going to decide if we really need to start antibiotics or not. And I would urge all the pediatricians who are listening to avoid starting antibiotics upfront on day one, day two. There is no role of antibiotics so early. Most of the times it is going to be a viral infection only. And so rigorous follow-up is all that is required with proper early treatment.
very good. And here I will just give you one important clinical clue between viral and bacterial pneumonias. See, these influenza like viruses, which also are known to produce viral pneumonias, the onset is with cold and cough and fever. So, cough is very much at the onset of the illness, and that is a very important clue for a viral pneumonia. Okay, while bacterial pneumonias initially have high fever, we always say, no, child, the parents they say, sir, the child has cold, cough, and fever. So I ask them, what is more? So the mother says, no, sir, the fever is so high that I had to give paracetamol every 6 hours. And I asked her, how bad was the cough? She said, no, cough was not that much, but the child has grunting and breathlessness and respiratory difficulty. And then after 4 or 5 days, so this is, more, seen in case of, say, bacterial pneumonias, where during resolution, the cough comes up. So the cough at the onset of the illness usually goes in favor of virus. Of course, in medicine, nothing is 100%, but this only something which our colleagues can remember. And after 4, 5, 6 days, maybe when the resolution begins, in case of bacterial pneumonias, the cough comes up. So this is only a clinical pointer. And maybe after Dr. Natu, there is one additional question which I always, would like you to answer, and that is related to these throat swabs. Both of you have told that, in certain situations we go ahead with these swabs, but then the report may not always favor influenza. Sometimes you get rhinoviruses, sometimes you may get the swab negative. How good are these tests, because those who do not do the test, many times I have seen they feel guilty that I don't have these facilities, and in Pune you are doing these tests every day on different patients. So is there something to be, guilty about not being able to send, these throat swabs?
So, a very important question, because it is to be remembered that testing is mandatory only in a small subset of patients. Majority of patients do not need any testing to decide the course of treatment. We already seen the category A and B do not require testing at all. Category C is the only category which will require testing. Having said that, the tests have a very good, what you can say, performance, in the sense that if they are positive, there is no doubt. There is hardly any situation where you get a false positive for H1N1 or H3N2. But if you get a negative test for, say, influenza viruses, but the epidemiological setting is such that influenza seems to be the most likely diagnosis, then you should go ahead and treat, not depend only on the test, because the test to some extent depend upon how the swab has been taken, whether the swab has been taken from the nasopharynx very properly, whether it has been taken in the oropharynx as well, and so on and so forth. So these technical points can affect the result sometimes, and hence a negative test should not rule out the possibility of a particular infection if the clinical situation tells us that it is influenza.
Right. So that's very important. And what is your opinion about, those viruses like RSV and adenoviruses? And which viruses will you take up as ones which are definitely, pathogenic, and which are the ones which are not really troublesome?
So influenza, as I said, in the epidemiological setting, it's most of the times pathogenic. RSV, again, in this typical season, is also going to be pathogenic, especially in younger children. Adenovirus, especially if the clinical situation is like pharyngocongenital fever and all, then adenovirus is going to be the causative organism. But there are certain other viruses which may not be, which may be just commensals there sitting there in the nasopharynx and which come positive, but which may not be pathogenic as such. For example, a Boca virus may not be the causative organism for the particular symptoms. And then these viruses, the results, if they come positive for these viruses, they can well be neglected.
Okay, very good. Dr. Sainath, there is a question about how well is oseltamivir tolerated give to an adolescent, and whether there are any major adverse effects of oseltamivir. What is your opinion?
No, sir, there is no, it is very well tolerated. The test is also fine. So generally, children do accept it very well. And there is no major side effect per se of oseltamivir, because we are using now in this season, we are almost used oseltamivir with light left symptom, because the season was like that only. That most of the patient would not improve without oseltamivir. So, but there is no side effect as documented as such, very minor side effect. These are also theoretical side effect. Practically, we have not seen any side effect per se.
Okay,
Nausea,
very good.
vomiting also we have not seen, sir, actually. Theoretical
Okay,
side
very
effects are there, but practically we are not seeing any side effects.
okay. And Dr. Nathu, these children with influenza, many times, they come with very high fever and we have to give them antipyretics. So what is the precaution related to the type of antipyretics to be used, particularly in influenza?
So we would use paracetamol only in influenza. Aspirin is definitely not to be used because of its association with the Rye syndrome, which has occurred previously in several children who have received aspirin in a setting of influenza. So aspirin definitely no. Paracetamol is the antipyretic of choice, which is to be used in influenza.
Okay, that's very great. And then, Dr. Sainath, some of our listeners have a question, and one of the listeners wants to know that there is an elder sibling of an 8-month-old child who is admitted with influenza A for low respiratory infection, the elder sibling, and this younger one has developed fever today. In this situation, whether we should start oseltamivir for this younger child?
Yes, sir. If the elder child is diagnosed case of influenza virus, definitely, as we has already discussed, it is better to start early if you are suspecting. So definitely in this patient, it is justified to start oseltamivir very early, because already we have got a diagnosed case which is his sibling only. So definitely they have got a contact, and contact is positive. So definitely we should start oseltamivir early in this patient, in this scenario.
Right,
Absolutely right.
right.
I would agree with Dr. Sainath. The only thing is, for example, if there's an elder sibling also, say 15-year-old, again presenting with fever, I would not be very keen as per the guidelines. If the symptoms are mild, I would probably not start. But for an 8-month-old, definitely yes, he falls in category B, being a age group less than 2 years. So yes, definitely I would also agree and start oseltamivir to this child.
Right. And Dr. Sanjay, in case if the child is not accepting the oral medicines at all, is there any alternative?
At present, unfortunately, there is no alternative for oseltamivir or any other antiviral which is available. So, for influenza, that is, so oseltamivir has to be given orally itself. The only precautions which I advise in my patients is it is as far as possible not to be given on empty stomach, because it does cause some gastritis and some gastric irritation sometimes. So, best to be given on full stomach. And fortunately, most of the patients have been able to tolerate oseltamivir quite well.
Yeah, okay, very good. And then, Dr. Sainath, there is a lot of influenza in the atmosphere these days. So if a child comes to you with high-grade fever, severe sore throat with cough and cold, is it an indication for starting oseltamivir in the current situation?
Yes, sir. Depends actually. If it is a, I mean, as depend day one, I would not start an OPD basis. But if the patient is having same symptoms after 3 days, in actually in this case, we have to just see the throat properly. If there is a clear cut leak, sometime it may look like bacterial also. If it is clear cut bacterial, I would prefer antibiotic there. And if he is not improving with the antibiotic, then we may go on antiviral also, because a clear cut throat, red throat, may be bacterial also, sir, sometimes.
Right, you are
If
right.
there is a
So,
tonsillitis, and if there is a clear cut tonsillitis, clear cut throat redness, so it may be, and I will see the patient's toxicness also. If the patient is very toxic, I would go along with the antibiotic also. And if the patient is not very toxic and patient is okay, then we may think of oseltamivir also. So it is a
okay,
dicey situation, sir. It is a
yeah,
dicey situation.
Yeah, I can understand. So in this case, Dr. Sanjay, do you have any clue to in this particular dicey situation?
So, as we have discussed the guidelines, the categories are very clear. If it is just a plain simple cold, cough, and fever, which is not very severe, then you would probably just treat the patient symptomatically and follow up, as has been stressed previously. Follow up is very important. But if the symptoms are severe, or if the patient has some predisposing factors, then yes, upfront, or if amongst the predisposing factor, of course, is the age. So younger child, for example, I would definitely upfront start oseltamivir in such a situation, depending also on the epidemiological situation. Like in the community, if there is a lot of influenza cases, then I'd err more on starting oseltamivir rather than not starting it.
Right, it's good. And so if you get parainfluenza virus on the throat swab, does oseltamivir work on parainfluenza virus?
Actually, no, it doesn't. It is specifically for the influenza virus. Parainfluenza virus just requires symptomatic treatment and the child should improve on its own.
Very good. So, with all that, I think we have covered almost all the important points related to the management of influenza and oseltamivir. So, we understand that this particular virus, I may say, is a fast and a furious virus with abrupt onset, high transmissibility. It's a very highly contagious virus, rapidly progresses, as we have seen. And some of the children we saw also develop ARDS. And we have to act really quickly. Even oseltamivir we have to give very, very quickly. The most important thing is, children are the ones who primarily transmit it to the adults. In case of COVID, the situation was a bit different, where adults would get infected first and then they would transmit it to children. So the preventive measures, basically the vaccine also, everything is concentrated in case of influenza towards children, so that the household contacts who are likely to be in the high risk category, they are not in trouble. And we also should remember that in addition to vaccine, we have to take care of certain things which start with the alphabet H. For example, hand washing, avoiding hand shaking, using a handkerchief, also keeping other person at a hand's distance, and also avoiding the hand touching. So with that, I say namaste to all of you, and not shake hand. Of course, in a virtual meeting it is not possible to shake the hand, but I would just say namaste, and that will keep influenza virus away from almost all of us. So with that, I thank Dr. Sanjay Nathu, Dr. Sainath Pawar, and Hetero for allowing us to express our expertise for the benefit of our listeners, and I hand over the proceedings to Dr. Prashant. Thank you.
Thank you,
Thank
sir.
you,
Thank
sir.
you so much. As usual, it's very lively, and thanks for sharing experience. Dr. Nathu, Dr. Pawar. I mean, we get feedback from the interiors how the cases are unfolding. And with this weather, I suppose influenza is still likely to continue for some long. Thanks once again, and thank all the doctors who took time. I'm sure they have benefited out of our interaction and inputs. And thanks IT team Nagadevi, thanks Samriddhi, and thanks sales team of Hitro for this super coordination. Thank you so much, all of you, and wish you a very pleasant
Thank you.
evening. We can
Thank you.
sign off, sir.
Yes.
Thank you.
Thanks,
Thank
sir.
you. Thank you, sir. Thank you,
Bye
sir.
bye.
Yes.
Good
Yes.
to.
Thank you.
Thank you, sir.
Thank you,
Bye.
sir.